Welcome back to the Deep Dive.
Thanks for having me back.
So for you listening today, our mission is to, decode one of the most deceptively complex, frankly, kind of chameleon-like illnesses in pediatric medicine.
Oh, definitely chameleon-like. It hides so well.
Right. And we're looking at a pretty massive stack of clinical sources today. We're anchored by material like Nelson's Textbook of Pediatrics, plus a wealth of current urological research to comprehensively unpack pediatric urinary tract infections.
And, just to be clear up front, we are completely bypassing the basic overview.
Yeah, exactly. You already know what a UTI is.
Right. What we're doing today is mapping the exact clinical journey. We're going from the cellular pathology and presenting complaints, through the anatomical risk factors, the biochemical lab markers, the nuclear radiology, and finally into the precise pharmacological mechanics of treatment.
Which is a lot, I know. But we're doing this because the stakes are just incredibly high.
Yeah.
I mean, our data indicates that pediatric UTIs are the leading cause of prolonged hospital admissions for nosocomial infections in children.
Yeah, hospital-acquired infections. It is an immense burden on pediatric wards.
For sure.
Because, a localized infection in the bladder is one thing, right? But we are looking at the pathophysiology of ascending infections that result in severe morbidity.
We're talking permanent damage here.
Absolutely. We are talking about irreversible pyelonephritic scarring, the insidious onset of secondary hypertension, and this is the big one, the progression to end-stage renal failure.
Wow.
Yeah, the damage sustained during a single severe febrile UTI in infancy can compound silently over the next 2 decades, ultimately requiring dialysis or even transplantation.
Which means catching it at the clinical presentation phase is essentially a race against permanent fibrotic damage.
Exactly. It's a race you do not want to lose.
But capturing an accurate history in pediatrics is, well, it's inherently flawed, right? Because your primary patient literally cannot articulate their pathophysiology.
Right. They can't tell you where it hurts. You are entirely reliant on the parental proxy and, your own clinical observation.
So let's break that down. If we look at the older pediatric demographic, the symptomatology aligns pretty well with standard lower urinary tract inflammation.
Yeah, it's what you'd expect.
You see the classic dysuria, the intense urgency and frequency. You're observing suprapubic pain right over the bladder dome, and potentially mechanical signs like straining to void or a poor urinary stream.
And that poor stream is a critical mechanical indicator.
Really? How so?
Because it immediately shifts the diagnostic focus. It goes from just simple mucosal inflammation to a physical outlet obstruction.
Oh, I see.
Right? So if the detrusor muscle is contracting but the stream is weak, there is a structural impediment in the urethra. It's not just an infection, it's a plumbing blockage.
Makes sense. And furthermore, the sources mentioned that the presence of malodorous urine in these older children points directly to bacterial metabolic byproducts.
Yes.
Specifically, those volatile organic compounds produced by certain gram-negative organisms accumulating in the bladder.
Exactly. But the clinical picture completely fractures when we look at neonates and infants.
Right, the localized signs basically vanish.
Completely vanished.
Yeah.
Our sources detail a presentation that is dangerously nonspecific. We're talking poor feeding, generalized irritability, and a failure to thrive or gain weight.
Which is terrifying because it's like the localized inflammatory response in the urothelium is somehow triggering a massive systemic metabolic shutdown.
That's exactly what's happening. We are seeing the effects of a systemic cytokine storm.
Okay, unpack that for us.
So, in a neonate, the immune system is relatively naive. When pathogenic bacteria breach the uroepithelium, the local macrophages release massive amounts of interleukin-1 and tumor necrosis factor alpha.
TNF-alpha.
Right. Now, in a mature system, like an adult, this might remain somewhat localized, but in an infant, these cytokines spill immediately into the systemic circulation.
So they're just flooding the whole body.
Flooding it, they cross the blood-brain barrier, altering the hypothalamic set point to cause fever and suppressing the appetite centers.
Wow. So the poor feeding and weight loss aren't primary gastrointestinal issues at all.
Not at all. They are the result of the brain redirecting all available metabolic energy away from growth and digestion. It funnels it entirely into the immune response.
So the lack of specific localized symptoms is actually a hallmark of the infant's inability to compartmentalize the infection.
Precisely. They just can't wall it off.
But to complicate the clinical picture even further, our sources detail this phenomenon of asymptomatic bacteriuria.
Oh, yeah. This is fascinating.
Right. We see positive urine cultures, like robust colonies of bacteria thriving in the urinary tract with absolutely zero clinical symptoms. no inflammatory response, and no subsequent renal scarring.
And statistically, this occurs predominantly in females.
Which is wild.
It fundamentally challenges our definition of infection versus colonization. In asymptomatic bacteriuria, the bacteria are present, yes, but they are lacking the specific virulence factors necessary to trigger the host's innate immune receptors.
Specifically the toll-like receptor 4, right? The TLR4 on the uroepithelial cells.
Exactly. Without TLR4 activation, there is no cytokine release.
No inflammation.
No dysuria, nothing. The bacteria establish a tolerogenic relationship with the host. They simply occupy the ecological niche in the bladder, they consume nutrients, but they cause no tissue invasion.
Which means treating asymptomatic bacteria with antibiotics might actually be counterproductive then.
Highly counterproductive.
Because you would be eradicating a benign colonizer, potentially leaving the ecological niche wide open for a highly virulent tissue-invading pathogen to just take over.
Precisely. It is a protective colonization in many respects. The clinical guidelines have shifted dramatically away from treating asymptomatic colonization precisely to avoid opening the door to virulent strains.
So let's look at how these pathogens gain access to the system in the first place, the etiopathogenesis. The overwhelming majority of these are ascending infections, right?
Yes, the ascending route.
So the bacteria originate in the bowel flora, they colonize the perineum, enter the urethra, and migrate upward against the flow of urine into the bladder and ureters.
Right. The proximity of the anatomical structures makes this highly efficient for the bacteria. I mean, the gastrointestinal tract serves as a massive, constantly replenishing reservoir for these uropathogens.
But our Nelson's data highlights a distinct mechanism for neonates, the hematogenous route.
Yes, the blood-borne route.
Right, because if the standard model is an ascending plumbing issue, a blood-borne infection implies a complete bypass of the lower urinary tract. The bacteria are essentially arriving at the kidneys from the inside out.
Which is unique to neonatal physiology. In the first few weeks of life, infants are highly susceptible to transient bacteremia.
So bacteria just circulating in the bloodstream.
Exactly. Often originating from the umbilicus, or the immature gut lining. And because the kidneys receive roughly 20% of the total cardiac output to filter the blood, any bacteria in the circulation are delivered directly to the renal parenchyma in massive volumes.
And the baby's defenses aren't ready for that.
No. The neonatal blood-kidney barrier is highly permeable. It allows these circulating pathogens to seed directly into the renal tissue, bypassing the bladder entirely.
Wow.
But as the child matures, the capillary endothelium in the glomerulus tightens up, rendering this hematogenous route practically impossible in older children.
Let's isolate the specific pathogens exploiting these routes, because the undisputed dominant force responsible for the vast majority of cases across all age groups is Escherichia coli.
Good old E. coli.
But we're not talking about standard gut commensal E. coli here, are we?
Oh, no. These are uropathogenic E. coli, or UPEC strains, and they possess a highly specialized arsenal for ascending the urinary tract.
The UPEC strains are formidable.
Very. Their defining characteristic is the expression of specialized adherence organelles called fimbriae, specifically type 1 PLE and P. fimbriae.
Okay, break down how those work.
Well, the type 1 PLE bind aggressively to the mannose-cylated proteins on the surface of the bladder epithelium.
So they just latch on.
They do. This allows the bacteria to anchor themselves firmly, resisting the sheer mechanical force of urination that would normally just flush them out.
So they are structurally anchoring to the bladder wall, and then the P. fimbriae take it a step further.
Oh, absolutely. They specifically target the Galgal receptor moieties, found higher up on the cells of the ureters and the kidneys.
Wait, so the bacteria literally switch their fimbrial expression as they ascend?
Yes.
Using different molecular anchors depending on which specific tissue they're trying to invade.
Exactly. It is phase variation at its most efficient. It's incredibly sophisticated.
That is terrifyingly smart.
Hmm.
But E. coli isn't the sole threat. The clinical sources outline a broader spectrum of enteric organisms, like Klebsiella, which utilizes a thick polysaccharide capsule to evade phagocytosis by white blood cells.
Right, and Pseudomonas, which is notorious for forming impenetrable biofilm.
And Proteus. We have to talk about Proteus, which fundamentally alters the chemistry of the urinary tract.
Proteus mirabilis is a particularly dangerous player because of its enzyme production. It secretes urease.
And urease hydrolyzes the urea in the urine into ammonia.
Exactly, which dramatically raises the urinary pH, creating a highly alkaline environment.
And that alkalinity is what causes the precipitation of magnesium, ammonium, and phosphate, right?
Yes, leading directly to the formation of massive struvite kidney stones. The bacteria essentially build their own calcified fortresses inside the renal pelvis.
Wow. Building their own fortresses.
Yeah, and the stone formation creates permanent physical stasis, making the infection incredibly difficult to eradicate. You basically have to remove the stone to cure the infection.
And we also see gram-positive cocci, like Enterococcus and Staphylococcus epidermidis, particularly in patients with indwelling catheters.
True.
The sources even highlight viral pathogens like adenovirus, which is a primary culprit behind acute hemorrhagic cystitis, causing profound bladder inflammation and macroscopic hematuria without any bacterial presence.
Right, which makes diagnosis tricky. Because given that viral infections like adenovirus can mimic bacterial cystitis and systemic cytokine storms in infants mimic entirely different diseases, the clinical differential diagnosis becomes incredibly fraught.
So what else is on the differential?
The sources mandate ruling out malaria, pneumonia, otitis media, and severe pharyngitis in any child presenting with a fever of unknown origin.
Just because the overlap in clinical presentation is due to the shared inflammatory pathways, right?
Exactly. Whether the pathogen is a Plasmodium parasite in the erythrocytes, a pneumococcus in the alveoli, or E. coli in the renal parenchyma, the systemic response is identical.
The fever, the lethargy, the elevated acute phase reactants.
Right. You cannot differentiate a lobar pneumonia from pyelonephritis based solely on the systemic inflammatory markers.
You have to look for the specific risk factors to guide the investigation. Which brings us to the demographic data. And the data regarding risk factors reveals a massive epidemiological reversal.
The big flip.
The big flip. According to the data, in the neonatal period and early infancy, males outnumber females in UTI incidence by a ratio of roughly 3 to 5 to 1.
Yeah.
But as we move past infancy into the toddler years, the ratio violently inverts. Females suddenly outnumber males 10 to 1.
And that epidemiological flip maps perfectly onto the shift from anatomical risk factors to behavioral and environmental ones.
How so?
Well, the initial male dominance is almost exclusively driven by congenital anomalies of the urinary tract. Male embryology, specifically the development of the Wolffian ducts and the complex formation of the male urethra, is highly prone to structural errors.
So they're just born with anatomical disadvantages.
Exactly. These infants are born with mechanical obstructions or refluxing systems that immediately predispose them to infection.
But by age 3, the female anatomy takes the statistical lead. The female urethra is significantly shorter, drastically reducing the physical distance the enteric bacteria must travel from the perineum to the bladder.
Right.
And this age perfectly coincides with toilet training.
Yes, which is the behavioral component. The mechanics of wiping back to front effectively drag the highly concentrated bowel flora directly across the urethral meatus.
It is the perfect storm of a shortened anatomical barrier and a massive increase in bacterial inoculation.
Completely.
Let's dissect the congenital anatomical defects driving that early male spike. The most prevalent anomaly identified in the sources is vesicoretral reflux, or VUR.
VUR. This is a primary failure of the urovesical junction.
Right.
Under normal physiological conditions, the ureter enters the bladder wall at an oblique angle, creating a sort of submucosal tunnel.
Okay.
As the bladder fills and the decruiser muscle contracts during voiding, it compresses that tunnel. It creates a one-way flap valve that prevents urine from flowing backward.
But in VUR, that submucosal tunnel is congenitally shortened or absent entirely.
Exactly. The valve mechanism fails.
So when the detrusor muscle contracts, generating all that immense pressure to expel urine through the urethra, it simultaneously forces a column of urine backward.
Right up the incompetent ureter, directly into the renal pelvis.
Wow. It transforms the bladder from a safe storage vessel into a high-pressure pump that drives any lower urinary tract bacteria straight into the deep medullary tissue of the kidney.
It's devastating, and VUR is just the beginning. The sources also detail posterior urethral valves, or PUV.
Right.
These are obstructive membranous folds within the lumen of the male prostatic urethra. PUV is a profound embryological failure.
How do those folds act?
Those tissue folds act like a sail. They catch the outflowing urine and balloon outward to completely occlude the urethra.
Which means the bladder has to hypertrophy, it has to build massive muscle mass just to push urine past the obstruction.
Yes. And this leads to severe urinary stasis behind the valve. And as we know, stasis is the ultimate prerequisite for bacterial multiplication.
The structural defect list continues, right, with ureterosleys.
Yes, which are cystic dilations of the distal ureter where it inserts into the bladder. They often cause an obstruction that leads to hydronephrosis.
And hydronephrosis is the severe distension of the renal pelvis and calluses due to the back pressure of undrained urine.
Right. We also see bladder diverticula, which are herniations of the bladder mucosa through the muscular wall.
Creating stagnant pools of urine that the detrusor muscle cannot effectively empty.
Exactly. And we also have to account for neurogenic functional disorders. Like in a condition like spina bifida, the neural pathways controlling the detrusor muscle and the external sphincter are disrupted.
Causing detrusor sphincter dysynergia.
Right, where the bladder contracts to empty, but the sphincter simultaneously clamps down instead of relaxing,
So the bladder is fighting against a closed door.
leading to high-pressure retention and inevitable infection.
It's just a cascading series of anatomical failures.
It really is.
But beyond the gross anatomy, the external anatomy presents its own risks. The clinical data shows a 10 to 20-fold increase in UTI incidence among uncircumcised males compared to circumcised males in the first year of life.
Yeah, that prepuce, or foreskin, creates a highly specific microenvironment.
The intermucosal surface of the prepuce has a high density of receptors that are highly susceptible to colonization by P. fimbriated E. coli.
Exactly. It acts as a sheltered, warm, moist reservoir. The bacteria colonize the preputial space, they exponentially increase their numbers, and they continuously inoculate the adjacent urethral meatus.
So removing the prepuce eliminates the reservoir and changes the local microbiome.
Right, which explains the drastic reduction in incidence.
And the interconnectedness of the pelvic organs also brings bowel habits into play, doesn't it? Constipation is a primary risk factor.
It's huge. The rectum and the bladder share restricted space within the bony pelvis, and they share parasympathetic innervation via the pelvic splanchnic nerves.
Right, so when the rectum becomes severely distended with impacted stool, it physically compresses the posterior wall of the bladder.
And that mechanical compression distorts the bladder geometry. It prevents complete emptying and increases the post-void residual urine volume.
Plus, the chronic stretching of the pelvic floor muscles from constipation can alter the neural feedback loops, right?
Yes, causing the child to subconsciously tighten the pelvic floor during urination, which mimics a functional obstruction. Resolving the constipation removes the physical mass and resets the neural pathways, allowing the bladder to empty efficiently.
Okay, so understanding these anatomical and environmental prerequisites allows us to contextualize the physical examination. The clinical classification of the infection depends entirely on how far the pathogen has ascended,
Correct. We start with urethritis and cystitis.
which is inflammation localized strictly to the urothelium of the lower tract.
Right. The mucosa becomes hyperemic and edematous, but because the infection remains superficial, it rarely elicits a systemic febrile response.
Because the urothelium is a highly effective barrier.
It is. As long as the bacteria are confined to the lumen and the superficial mucosal layers of the bladder, the systemic inflammatory mediators aren't heavily triggered. The symptoms are purely localized pain and urgency.
But when the bacteria breach the ureterovesical junction and ascend to the renal pelvis, we classify it as pyelitis. And when they invade the deep functional parenchyma of the kidney, we have clinical pyelonephritis.
And that is the inflection point where permanent damage occurs.
Right.
In pyelonephritis, the bacteria infiltrate the renal interstitium and the medullary pyramids. The resulting inflammatory cascade causes massive local tissue edema.
And that's what stretches Gerota's fascia.
Exactly. The kidney swells against the restrictive, fibrous renal capsule, Gerota's fascia. This rapid stretching of the highly innervated capsule is what causes the profound flank and loin pain observed on examination.
So the physical examination of a child with pyelonephritis reveals a patient in systemic crisis. Alongside the severe flank tenderness, they present with rigors, malaise, nausea, and vomiting.
And those rigors are just the physiological manifestation of the body violently attempting to raise its core temperature to optimize white blood cell function and inhibit bacterial replication.
And the nausea and vomiting.
Secondary to the massive release of inflammatory cytokines disrupting the gastrointestinal motility pathways.
And when we transpose this severe systemic response back onto neonates, the physical findings become bizarrely counterintuitive, don't they?
Oh, completely.
Because a neonate with severe pyelonephritis often presents primarily with jaundice and diarrhea.
Which throws a lot of people off, but the neonatal jaundice is a direct result of endotoxemia.
Okay, explain that connection.
So the lipopolysaccharides from the cell walls of the gram-negative bacteria circulate to the liver, and they actively downregulate the expression of the canalicular bile salt export pumps.
So the liver just stops pumping bile.
Pretty much. The hepatocytes simply stop excreting bilirubin into the bile ducts, causing it to back up into the bloodstream.
Wow.
It's a functional cholestasis driven entirely by the renal infection.
So the clinical presentation can be an absolute mirage, which is why the visual and physical examination must be immediately corroborated by objective laboratory data. The sources are definitive. Urine microscopy and culture are mandatory.
Mandatory. You cannot skip them.
But securing an uncontaminated sample from a pediatric patient requires navigating significant logistical and anatomical hurdles.
Understatement of a year.
Right. In an older continent child, a midstream clean catch is the standard. You allow the initial void to mechanically flush the distal urethra of its normal commensal flora, capturing the midstream urine, which accurately represents the bladder environment.
Right. It relies on the mechanical shear stress of the initial urinary flow to clear the pathway.
But in infants, the clean catch method, basically cleaning the perineum and waiting for a spontaneous void into a sterile container, is fraught with high false positive rates.
Very high. The perineal skin is heavily colonized, and capturing the urine without contact is exceedingly difficult.
So if non-invasive methods fail, the clinician escalates to urethral catheterization. You introduce a sterile, lubricated catheter directly through the urethra into the bladder.
Yes, but even that has risks.
Right. However, the most definitive zero-tolerance method detailed in the sources, particularly for neonates, is the suprapubic aspiration.
The suprapubic aspiration bypasses the entire colonized lower anatomy.
Which sounds intense.
It is. Using ultrasound guidance to confirm the bladder is distended, a needle is advanced percutaneously through the sterile abdominal wall, directly above the pubic symphysis, straight into the bladder lumen.
So you're drawing the fluid directly from the source.
Exactly. Because the needle never touches the mucosal surfaces of the urethra or the perineum, the sample you extract is pristine. If there are bacteria in a suprapubic sample, they are undeniably in the bladder.
Okay, so once that sample is secured, the biochemistry of the transport is critical. Because urine is an optimal growth medium, right? It's warm, it contains urea, creatinine, and trace carbohydrates.
Right. If a sample sits at room temperature, a clinically insignificant level of urethral contamination will exponentially multiply into what appears to be a massive infection within hours.
Just a total false positive. To arrest that replication, the sources mandate refrigeration at 4 degrees Celsius, which rapidly slows bacterial metabolism. Alternatively, the sample can be transported in a 1.8% boric acid solution.
Which is brilliant because boric acid is bacteriostatic.
Meaning it doesn't kill them, it just stops them.
Right. It penetrates the bacterial cell wall and interferes with essential metabolic enzymes, effectively halting cell division without actually lysing or killing the bacteria.
So this preserves the exact colony count present at the moment of collection, and it maintains the structural integrity of the white blood cells for accurate microscopy.
Exactly. And when the laboratory processes the sample, they utilize specific growth media. Blood agar provides a rich, non-selective environment to grow fastidious organisms.
While MacConkey agar is a selective and differential medium.
Yes. It contains bile salts and crystal violet that actively inhibit the growth of gram-positive organisms.
So that allows the laboratory to isolate and identify the gram-negative enteric bacilli like E. coli and Klebsiella that dominate UTI pathology.
Which brings us to the diagnostic thresholds. These cultures are rigidly defined by the collection method.
Right, the numbers change based on how you gate the P.
Exactly. For a standard midstream specimen, the threshold for a positive diagnosis is a pure growth of 10 to the power of 5, or 100,000 colony-forming units per milliliter.
That high threshold mathematically accounts for the expected contamination from the distal urethra. You need a massive bacterial load to confidently separate a true bladder infection from background noise.
Exactly. But when you look at a catheterized specimen, the threshold plummets to 10 to the power of 4, or 10,000 CFU per milliliter.
Because the catheter bypasses the perineum. But as it passes through the distal urethra, it can inadvertently drag a small number of commensal bacteria into the bladder.
Right, so you allow a much smaller margin for that specific mechanical contamination.
But for the suprapubic aspiration, the threshold is absolutely binary.
Completely binary.
Any growth at all, even a single colony-forming unit, is diagnostic of an infection, because that needle path must be perfectly sterile.
Spot on. And alongside the microbiological culture, the laboratory quantifies the host's immune response through microscopy. We are looking for pyuria.
The presence of white blood cells, specifically neutrophils, in the urine.
Right. The diagnostic criteria require 10 white blood cells per cubic millimeter in uncentrifuged urine, or greater than 5 in a centrifuged sample where the cellular components have been concentrated at the bottom of the tube.
And the systemic blood markers provide the broader inflammatory context. Leukocytosis, an elevated erythrocyte sedimentation rate, and a high C-reactive protein level.
CRP, yeah.
All of those indicate that the body is synthesizing acute phase reactants in the liver to combat a deeply invasive infection, heavily weighting the diagnosis toward pyelonephritis rather than superficial cystitis.
Right. And while we wait 48 hours for the culture to incubate, the point-of-care dipstick chemistry provides immediate actionable data.
Let's talk about the dipstick.
So, the leukocyte esterase pad on the dipstick tests for the presence of azurophilic granules, which are unique to the cytoplasm of neutrophils. A positive result confirms that the immune system is actively shedding white blood cells into the urinary tract.
But the nitrate test on the dipstick is where the true biochemical kinetics come into play. Normal urine contains dissolved nitrates with an A derived from dietary protein metabolism.
Right.
And many enteric bacteria, notably E. coli, possess an enzyme called nitrate reductase. This enzyme metabolizes the urinary nitrates, reducing them into nitrites with an I. And the dipstick region only reacts to nitrates.
And here's the clinical caveat: enzyme kinetics. The reduction of nitrate to nitrate is not instantaneous.
It takes time.
A lot of time. The bacterial reductase requires continuous exposure to the substrate. The clinical consensus dictates that the urine must incubate in the bladder, in contact with the bacteria, for a minimum of 1 to 4 hours,
Wow.
just to accumulate enough nitrite to trigger the chemical color change on the dipstick.
Which exposes a massive vulnerability in the test. The primary symptom of a UTI is severe urinary frequency. If the detrusor muscle is highly irritable and the child is voiding every 20 minutes, the urine is constantly being evacuated before the nitrate reductase enzyme has time to process the chemicals.
Right. You will get a false negative nitrite reading, even with a massive E. coli infection, simply because of the rapid fluid turnover.
The chemistry requires stasis, but the pathology drives frequency.
It's a perfect paradox, and it demands clinical intuition over blind reliance on a dipstick.
Okay, so once the laboratory confirms the presence of the pathogen, we transition to evaluating the anatomical battlefield. We need to visualize the structural landscape to identify the underlying defects we discussed earlier, and to assess the extent of any permanent tissue damage.
And the radiological guidelines mandate imaging for all children with recurrent UTIs, acknowledging the staggering 30 to 40% recurrence rate in female patients.
Right, so the initial non-invasive modality is ultrasonography. Ultrasound utilizes high-frequency acoustic waves to map tissue density based on acoustic impedance.
It is exceptional at identifying fluid-filled structures. It can instantly differentiate a solid renal tumor from the anechoic black voids of severe hydronephrosis.
And it can visualize the thickened bladder walls indicative of chronic cystitis and identify major gross anomalies like renal agenesis or multicystic dysplastic kidneys.
But ultrasound cannot dynamically visualize the flow of urine, which is why the clinical protocol dictates avoiding cystoarthrogram or VCUG.
And who gets a VCUG?
Highly specific demographics. All children under 5 years of age, all patients with a febrile UTI, females with recurrent infections, any male with a UTI, and all neonates.
Wow, that's a wide net. And the VCUG involves catheterizing the bladder, filling it with a radiopaque iodinated contrast dye, and utilizing real-time fluoroscopic X-rays to watch the dye during both the filling and the active voiding phases.
Yes. The primary objective of the VCUG is to dynamically capture vesicoreteral reflux. We are looking to see if the pressurized contrast dye sheets backward up the ureters.
And based on how far the dye travels, whether it just reaches the distal ureter or if it goes all the way up to dilate the renal calyces, we can grade the VUR from grade 4 to grade V.
Exactly. But there is a massive physiological risk built into the VCUG procedure.
The sterility rule.
The clinical guidelines absolutely mandate that a VCUG can only be performed when the urine is proven to be completely sterile.
Right, because if you introduce pressurized fluid into a bladder that is harboring an active bacterial colony, the retrograde pressure will inevitably force the infected fluid up into the kidneys.
You would be causing iatrogenic pilovenous backflow. You would physically drive the bacteria deep into the renal venous system, transforming a localized bladder infection into massive pyelonephritis and potentially lethal bacteremia.
So the architecture can only be tested when the pathogen has been entirely eradicated.
Yes,
For a more detailed static evaluation of the upper tract, tracts, the sources mention excretory urography, where intravenous contrast is filtered by the kidneys, highlighting the internal contours of the pelvic luteal system.
True. But the ultimate tool for evaluating functional damage is radionuclide renal imaging. We are moving from gross anatomical structure to cellular metabolic function.
Nuclear medicine.
Nuclear medicine relies on radiotracers. The sources highlight technetium-99 meter, a radioactive isotope that emits detectable gamma rays.
And the technetium is chemically bound to highly specific delivery molecules, such as DMSA, DTPA, or GHA.
Let's focus on the DMSA scan dimercaptosuccinic acid. It is the gold standard for identifying renal scars.
Because when DMSA is injected intravenously, it is specifically taken up by the megalin and cubalin receptors located on the cells of the proximal convoluted tubules in the renal cortex.
Right. The DMSA binds directly to the functional cellular machinery of the healthy kidney tissue.
Because the technetium is attached to the DMSA, the healthy, metabolically active cortex emits a bright gamma signal that the camera captures.
Beautiful, bright signals. However, in areas where a severe pyelonephritic infection has destroyed the nephrons, replacing the functional epithelium with dense fibrotic collagen scars mediated by transforming growth factor beta, there are no proximal tubule cells left to absorb the DMSA.
So the fibrotic scar tissue appears as a completely dark photopenic void on the scan.
Exactly. The DMSA scan doesn't just show you the shape of the kidney, it explicitly maps exactly how much functional tissue has been permanently deleted by the infection.
It visualizes the irreversible cost of the disease.
Which brings us to the paramount clinical challenge: treatment and prophylaxis.
Right. Because the acute management strategy is designed to halt the inflammatory cascade and eradicate the pathogen before those fibroblasts can lay down permanent scar tissue.
The immediate acute treatment relies on aggressive, broad-spectrum bactericidal agents. The sources specify the use of parenteral cephalosporins for 5 to 7 days.
And we don't wait for the 48-hour culture results to identify the specific bug. We strike immediately.
You strike immediately. Cephalosporins are beta-lactam antibiotics. They act by covalently binding to the penicillin-binding proteins located inside the bacterial cell wall,
which permanently inhibits the transpeptidase enzymes responsible for cross-linking the peptidoglycan chains.
Right. And without that structural cross-linking, the bacterial cell wall loses its integrity and the osmotic pressure differential causes the bacteria to literally explode.
A catastrophic structural failure for the pathogen.
Yes. And for neonates, the parenteral administration, giving the drug intravenously rather than orally, is extended to a 10 to 14-day course.
Why so long for neonates?
Because the neonatal gastrointestinal tract is highly erratic in its absorption rates, and neonates have a massive volume of distribution due to their high body water content.
So you have to use IV administration to guarantee that the drug achieves consistently lethal concentrations in the bloodstream.
Right, to combat that highly permeable blood-kidney barrier we talked about earlier.
Once the acute phase is managed, the follow-up culture is not optional, is it?
It is a strict clinical necessity to prove absolute sterility.
Because if the antibiotic course merely suppressed the bacterial count below the symptomatic threshold without achieving total eradication, the residual viable bacteria will rapidly remultiply.
Exactly, initiating a secondary inflammatory cascade and accelerating the fibrotic scarring process.
So for the patients identified with the severe structural risks, the high-grade reflux, the neurogenic bladders, the severe stasis, we have to deploy long-term chemoprophylaxis to prevent the inevitable recurrences. We are placing them on a daily chemical shield for 6 months, and in severe cases up to 5 years.
The pharmacological choices here are highly specific. The sources outline cotrimoxazole or nitrofurantoin.
Let's talk about cotrimoxazole. It's a synergistic combination of sulfamethoxazole and trimethoprim.
Right. It attacks the bacterial folate synthesis pathway at 2 sequential independent steps, completely starving the bacteria of the nucleotides required for DNA replication.
And nitrofurantoin is arguably the perfect localized weapon. Once absorbed, it is rapidly filtered and concentrated almost exclusively in the urine, achieving massive bactericidal levels in the bladder while maintaining negligible concentrations in the systemic tissues.
Inside the bacteria, bacterial flavor proteins reduce the nitrofurantoin into highly reactive intermediate compounds that viciously attack and shred the bacterial ribosomal proteins in DNA.
And the timing of the dose is the masterstroke of the regimen. By administering the drugs strictly at night, you capitalize on the physiological stasis of sleep.
Exactly. During the day, frequent voiding flushes the bladder. At night, the urine remains stagnant for hours. Dosing at bedtime ensures that the stagnant pool of urine is highly concentrated with the reactive nitrofurantoin, turning the bladder into a lethal holding tank during its most vulnerable hours.
But pharmacology is only half of the prophylaxis equation. The clinical guidelines demand a holistic restructuring of the patient's environment and anatomy.
It's crucial. This means surgical interventions like ureteral reimplantation to physically reconstruct the incompetent valve in vesicorectal reflex.
It means aggressively managing the bowel regimen to prevent the rectal distension from compressing the bladder neck.
Right. It involves meticulous perineal hygiene protocols and, where indicated, circumcision to eliminate the preputial bacterial reservoir.
The clinical goal is to combine the pharmaceutical suppression of the pathogen with a physical optimization of the urinary flow.
Yes, attacking it from all sides.
This entire journey really underscores the immense gravity of what might seem like a simple, localized infection. We've traced the pathology from the initial fimbrial attachment of E. coli to the systemic cytokine storm that masks the disease in infants.
We've navigated the complex anatomical failures of reflux and obstruction, analyzed the precise biochemical kinetics of the laboratory dipstick, and witnessed the permanent fibrotic damage illuminated by nuclear DMSA scans.
The depth of this clinical protocol, the strict rules surrounding sterile VCUGs, the aggressive parenteral cephalosporin regimens, the multi-year prophylaxis is entirely driven by the necessity to protect the developing renal parenchyma.
Right, because the kidney has a finite number of nephrons. Once they are destroyed by pyelonephritic scarring, they do not regenerate.
We are protecting the long-term metabolic filtration capacity of the child. But as we close this deep dive, consider the profound physiological contradiction at the heart of our treatment protocols.
Okay, what are you thinking?
Well, we established that the uropathogens driving these ascending infections originate in the gut microbiome. Yet, our definitive protective strategy for high-risk patients involves administering daily, long-term antibiotics like cotrimoxazole for up to 5 years.
Yeah, that's a rub.
While nitrofurantoin concentrates mostly in the urine, systemic drugs undeniably alter the intestinal flora. How does a developing pediatric immune system balance the absolute necessity of maintaining a sterile urinary tract against the chronic, multi-year disruption of the very gut microbiome that regulates fundamental immune and metabolic health?
That tension, the collateral damage of the cure, is the defining tightrope of long-term pediatric care. It's an incredible balancing act.
A profound biological trade-off to consider. Thank you for joining us on this exhaustive clinical journey today. We will see you on the next deep dive.